So first up, we have Dr. Tao Xie. He is a professor of neurology at the University of Chicago. He's a board-certified neurologist and fellowship-trained specialist in Parkinson's disease and other movement disorders. He currently serves as the director of the Movement Disorder Clinic and Deep Brain Stimulation Program, and is also the chief of the Neurodegenerative Diseases Department of Neurology at the University of Chicago. He is also the Director of Information and Referral Center of American Parkinson's Disease Association and the Director of Center of Care for Cure PSP. That was quite a mouthful. Thanks, Dr. Shea, for joining us today. And then secondly, we have Dr. Michiko Bruno. She is the Medical Director at the Parkinson's and Movement Disorder Center at the Queens Medical Center in Honolulu, Hawaii. She's also a professor of medicine, and her research interest is to identify and decrease the health and access disparities in this community. I really hope you'll enjoy their talks today, and hopefully you have questions that we can ask them at the end. All right, Michiko, I'm going to pass it over to you to share your screen.
Hello, everybody. Do you hear me? Can you hear me?
Yep.
Okay, thank you so much for joining us, having me, sorry, and joining. I'm so excited to have people from all over the country, all over the world even. So yes, I'm so honored to be here and part of Cure PSP. My talk is about expanding access to care. So, okay, can you see the next slide? Hopefully, yes. Okay. So I just wanted to introduce myself before I go start talking. I have some research funding from various organizations, but I also wanted to talk a little bit about myself, personal. I am a Japanese and now live in the United States. So I'm very interested in cultural difference and how our culture, as well as living conditions, shape our identity, health, and experience. And medicine, I feel like, is a very unique thing where we combine science as well as humanity. So that's kind of my interest. I also, before coming back to academic, I was in private practice. So I I have seen a lot of what's happening, boots on the ground, and wanted to translate that into academia. So that's sort of my focus, improving lives and reducing suffering now using the tools we already have. I mean, I guess I may be a little bit impatient. So I want to do things now, addressing gaps in care, implementing the low-hanging fruit. So that directly relates to relates to why it is so important to improve access to care and study diverse population. So I didn't really define access to care, but I think it is accessing for individual as well as a community, everybody, because suffering is universal, and especially in a disease like PSP, MSA, CBS, other neurodegenerative disease, there's of course the direct toll of disease, but in addition to that unknown, uncertainty, isolation, those adds another layer of distress. So there are ways that we can probably improve, at least we can't 100% remove the suffering or difficulty, but there are things we can try to improve the experience of this difficult journey. So that's what I'm very interested. And studying diverse population is also not just providing equity and inclusion, it also strengthens science by understanding differences in physiology and genetics, and environment across different population really has helped us understand the mechanism of disease, and ultimately that helps everybody. So this, you might be wondering what this picture is. I think sometimes I feel like when I'm talking to my patient, they think I know everything, like top to down, but I actually don't. So we really need this feedback of listening to you, studying things, understanding, improving, sort of a feed forward loop to improve the care and the management and treatment. So I'm so honored to be part of the Cure PSP Access Working Group. A couple of years ago, with the leadership of Dr. Dale, we published this viewpoint that patients with progressive supranuclear palsy need to be seen sooner and more frequently. I think we don't, you probably, some of the audience probably know this better than I do, but there is a challenge to receiving comprehensive care for PSP, CBS, MS, and other neurodegenerative disease for multiple reasons: lack of understanding or comfort with diagnosing among the healthcare providers, as well as, of course, lack of resources. There are financial, institutional barriers, communication from the healthcare team. So there's a lot of things we can tackle. Before I go into my community and my research, I just want to have a global view. There was a global review, and I apologize, I'm kind of bringing up PSP literature a lot because there's more to be done for MSA and CBS. They are even less common than PSP, so we need to do more for every disease. But in this review, it shows that actually the burden of disease like PSP is global all over the world, not just our own community. And the clinical presentation is similar, challenge and diagnosis prognosis is similar. But there are, of course, regional disparities as well. Diagnostic practices might differ, treatment accessibility might differ, and availability, access to research and clinical trials might be limited in different populations. And so we can do more to try to have to really, this is a village that we need to work across together. So yeah, so this is, I'm sorry that it says PD, but what I guess our research stems from, we want to improve our care in our community, but in order to do that, we need to first have data to understand what's happening. And so this is the beautiful state of Hawaii. So now I want to take you to Hawaii. I know a lot of audience, Courtney's in New York, very cold. Dr. Shay's in Chicago, I think cold. Some of you, I saw Toronto, different places. I think you're all cold. So I'm going to take you to a warm Hawaii, which is 80 degrees now. But Hawaii, so let's take you to a trip. Hawaii is in the middle of the Pacific Ocean, as you can see. So as beautiful as it is with unique biodiversity, rainforest, coral reefs, it's actually one of the most remote and isolated place on Earth. So that makes some of the healthcare access challenging. We're island states, so in order to get to the main, most populated island, Oahu, you have to fly. So that's always a challenge. And this is just to, add a little more, knowledge and being a little fun, learn something. Where did Hawaiian people come from? They are thought to be originated from Southeast Asia, Pacific Islanders. They built a canoe and amazingly used stargazing. This was before GPS, long time ago. Just looking at the star, they were able to travel all the way to Hawaii, go back and forth actually, and there were some commerce. So they were very smart, amazing people reading the nature. So this is just a brief history of Hawaii. So they were, as discussed, it was first inhabited by Polynesian settlers who did form individual tribes and used farming and fishing and had a very rich culture. But in 18th century, it was discovered by British explorers. And it introduced amazing things like trade, agriculture, religion, brought up the civilization, but it also brought difficult things, challenging things like disease, smallpox, plague, leprosy, and devastated native Hawaii population. Just a side note, Queen's Medical Center where I work was founded by Queen Emma during this time to try to help the health of native Hawaiian population. So demand for plantation labor led to immigration all over, especially East Asia, China, and Japan. And also far away from Europe, we have a large Portuguese population. Briefly, the kingdom was united by King Kamehameha, but then it was overthrown by the business leaders, annexed to US. And then we had Pearl Harbor 2 days ago. It was a Pearl Harbor anniversary, which is a difficult topic for me, but we all want to learn from our past mistakes. But what that led, not just the World War II, but in general, all these changes happened, which displaced Native Hawaiian who lost their land and fisheries and traditional way of living, and they were lured by Western diet, which is really great, yummy, but also high sugar and a little bit unhealthy compared to their traditional food, which led to epidemic in diabetes and obesity and cardiovascular disease. So there are healthcare inequity that persists to today. In Hawaii, people, again, it is a very multi-ethnic, diverse population. We still have many white people, but less compared to the this is the continental United States. So we have a lot of Asians, of course, Native Hawaiians, but we also have a lot of mixed race, which makes sort of health study interesting. And then all these other like Pacific Islanders, which I have a slide next. So we call them Pacific Islanders, but the Islanders themselves are a heterogeneous group. They're Micronesia, Melanesia, Polynesia. So they have different culture also. And I see patients from different language. Sometimes interpreters are not always available. Another thing, language defines disease and health and culture. So some of these cultures don't even have language for Parkinson disease, let alone, of course, probably not a typical Parkinsonism, but they don't even have a term to describe Parkinson disease. So the health disparities that I mentioned in Hawaii, as you can see, this is everybody, but life expectancy is very different amongst different race and ethnicity. So Pacific Islander population has the worst, but also Native Hawaiian is a little bit less healthy compared to the rest. White, Filipino, Korean, Japanese, Chinese, East Asians live a longer life. So in our own center, we wanted to look at racial disparity. Again, I apologize. We are just trying to embark on a typical Parkinson disease like PSP, MSA, CBS, which we'll talk about. But the majority first, we kind of analyze Parkinson disease in a hospital setting, which is again methodologically it's inadequate because most Parkinson patients actually don't necessarily come to the hospital. But this was the best data we had at the time. And what we found that was that NHPI, which means Native Hawaiian Pacific Islanders, were hospitalized at younger age compared to all other racial ethnic groups and had higher rates of comorbidities, which affect their health. And even within the Asian group, which we lumped together, Filipino patient had a worser, I guess, younger age as well as more comorbidities compared to Japanese or Chinese East Asian population. So I'm gonna skip, we're kind of repeating the same thing, but I guess the biggest question is why are there differences? Are there genetic? Are there biological? Or are there socioeconomic? And by teasing these out, I think will help everybody to improve the health. So in terms of progressive supranuclear palsy, we did a review of PSP patients encountered in Hawaii in our institute over like 15 years. And again, we showed that Native Hawaiians progress faster. They were actually younger at their age of onset and progressed faster compared to the Asians and white population. So again, repeating a little bit, repeating myself, but here is different genetics because this is just to show that there is a Parkinson gene that is known to kind of a very common variant compared in Philippines and Pacific Islanders and Southeast Asia originating. In general, it's a rare mutation, but it's a little more common in this population. So by studying these, we can understand the biological mechanism of all people with Parkinson's. So similarly, if we could study the genetics of PSP, MSA, CBS, we might be able to, even for people who don't have the genetic changes, that could help us understand the proteins and what biological changes happen better. But of course, there's probably a kind of contribution of environmental diet, lifestyle. That's why I kind of mentioned diet, which leads to cardiovascular, maybe inflammation, exposure of toxins like pesticides, air pollution, all those things can kind of contribute. And if you study, like my eventual hope is if we study like Japanese patient in the United States versus Japanese people in Japan, is there a difference? Same thing could be done for Filipinos. So if we compare different population, we might be able to understand the influence of lifestyle which is modifiable environmental factors. And then cultural, historical, and cultural attitude towards health may differ. So in our own Native Hawaiian population, you could see that they might have skepticism of Western tradition, and they might prefer to see a traditional healer rather than Western doctors or hospital. So that might be an issue, as well as, of course, socioeconomic factors. I want to pause and change a little bit of topic. So some of you may live in a little more rural areas, and and this is also another difficult disparity access and care issue between urban and rural centers. So I probably don't have to tell you, some of you may have to drive like hours to get to a major medical center. And this is even worse in Hawaii because people in different islands have to fly. There's no way to drive across the ocean. We used to have a ferry from Maui and Oahu, but it was discontinued because it took like 4 hours and there's loads of problems. So now the only way is to fly or do telehealth. So this is just to show that we studied what is the prescription pattern and the specialist and in rural defined by different islands. They've only like quarter patients even saw neurologists. A lot of them are managed by PCPs, which are they're very competent actually because they have to deal with a lot of medical problems, and we work with them very closely. But again, when it comes to like advanced treatment or very highly specialized treatment or even trials, they would have to travel a lot, and that is a burden and a difficulty that we want to try to tackle as best as we could. We did a survey to understand challenges and barriers faced by rural providers. What were the provider facing? And they're very engaged, interested, very competent, but they do know that there's a shortage of ancillary service such as social work or geriatric providers, mental health providers, support groups. So even individuals very competent, we want to have a more multidisciplinary support in different communities. So yeah, so that was just a very quick rundown of what we're doing. But next steps, I wanted to talk about how, and I really welcome everybody's input. If you have any thoughts, I would love to hear that. But Cure PSP, one of the mission, I mean, Cure PSP's mission, not one, is research, advocacy, education, and all of these are very intertwined to improving access, improving care. So these are all three very important things to try to, tackle this. It's a complex problem, but it could be done with collaboration. So Cure PSP is giving us a grant with Dr. Xie that he will be talking next, and we're collaborating to see what expanding some of the studies, understanding the disparities, not just PSP, but on MSA, CBS, also including more data about social determinants of health. So we're very excited to try to understand this better, as well as Access Working Group has projects. How do we improve to see patients sooner? How do we get to diagnose patients earlier? So those are things we're working on. But you can also help. So if you're a patient, you can definitely join Cure PSP genetic program. And as you could see, the understanding genetic also helps ultimately, not maybe tomorrow right away, but eventually it will help getting to a better understanding of the disease and treatment. And then there's also other surveys that we want to understand the financial impact that disease causes, like a secondary difficulty, not just the disease itself, but that brings a lot of difficulty and challenges. So we want to understand that and tackle not just like short scientific, like you just go to the doctor to get the prescription, but we want to think of this as a bigger problem holistically and with collaboration. So, yeah, so other things, education, I think is extremely important, bringing awareness to disease. So I also belong to Diagnosis and Treatment Working Group, and few years ago we published this paper and as a tool for the general neurologist or even community primary practitioner to understand, be aware, of these disease. And some of the PCP I work with now recognize it, which is amazing. They call me and say, "Hey, I think this patient may have a PSP or MSA," which is great. So increasing awareness and educating the the primary care, but also the next generation. So that's what we're working on as well. And also allied health. We can't do this alone, so we need to kind of build a village. Um, so yes, so those are things we're working on. And I wanted to thank you, mahalo, and pass it on now to Dr. J.
Mahalo. Thank you so much, Dr. Bruno, for your nice talk. And I also would like to thank you for your hospitality during the MDS meeting in October while we're all in Hawaii. It is a wonderful experience. I still learned a lot today, even though I visited there once. It's a wonderful place. Hello, everyone. Thank you for joining us. And also, I would like to take this opportunity to thank you, Cure PSP, for having us here to share with our experience and also get your input. I would like to talk to healthcare accessing atypical Parkinsonism, the same topic, but more at the single institute level, because this is also part of the grant, the study sponsored by CurePSP for us and for University of Hawaii. So this is my disclosure. Basically, there's nothing otherwise to disclose relevant to this talk. There's no conflict of interest. So I would like to provide a little bit of background why we would like to have this topic. Because the timely access to quality health care for individuals with atypical Parkinsonia syndrome, we also call it Parkinsonism, AP refer here in short, which include PSP, progressive supranuclear palsy, CBD, corticobasal degeneration. In a broader term, we also call CBS, corticobasal syndrome, and the MSA, multiple system atrophy. They are all very challenging as their rarity often delays the diagnosis. And the healthcare access situation for those patients is rarely studied and largely unknown in the literature, particularly in underserved and the minority population. And again, we're so grateful for the CurePSP Center as a center to get this support from CurePSP to study this important issue in both here, University of Chicago, and University of Hawaii, because we both take care of a large population of underserved minority populations. Here, University of Chicago, mainly Black / African American population, while Hawaii, mostly native Hawaii and Pacific Islands. Basically, this is a study for two centers of retrospective studies. So since it is rarely studied and nothing pretty much available through the literature search, as I often checked, and I did a recent search again, I did not find much new information. But we have been studying healthcare access and survival and the clinical feature in Black patients with PD compared to the counterpart of white patients for years, which really help us similarly study the patient with atypical Parkinsonism, particularly in Black patients. As University of Chicago is located at the south side of Chicago, home of a large Black community with about 1.1 million population there. So I just briefly summarize what we learned from our study in healthcare access in patients with Parkinson's disease. In general, we found disparity in healthcare access in Black patients with PD is they often present at old age, severe symptoms, less medication coverage, and less advanced therapy, but it could be more likely on supplementary therapy, including physical therapy, we call PT, occupation therapy, OT, speech therapy, we call ST, and the swallowing evaluation and the therapy as well, and also home health care service. Less often having the medical care at outpatient setting, but more often in the ER setting and the inpatient setting. Why is that? We found that the disparity in socioeconomic status and the mistrust of the healthcare system and the misconception about the disease could be contributing to this disparity, even though other factors, as pointed out by Dr. Bruno, genetic environment, culture, and other biological factors we are not quite understand so far, could also contribute. So those information would help us eventually try to find a better strategy to improve healthcare access by providing education to patient and a caregiver to make them aware of this disease so that they can seek healthcare in a timely manner, and also make sure that the healthcare provider are also aware of the healthcare disparity and the inequity and the facility timely access and provide quality care. So we have been studying the diagnosis, treatment, and clinical trial, and the survival in patients with atypical Parkinsonism for years. Those experiences also help us our current study in atypical Parkinsonism. We are particularly interested in how we can use the progression rate of Dyng's palsy to estimate the survival duration. It is very important because it could help us having a better clinical management plan for the care providers and for the patient and family, and also better engage them with palliative care, which could provide a better quality of care and a service, and also probably would help clinical trial enrollment as well. So with those experience, we currently are studying what is kind of the status of healthcare access and survival for patients with atypical Parkinsonism in our CurePSP Center at the University of Chicago. And we also would like to further analyze what is the impact of demographics, socioeconomic status, and comorbidity on those measures and identify the barriers. And eventually we'll try to use this information to help improve the timely access to quality of care for everyone, every patient, particularly for those underserved minority populations. So here's a message. We have been conducting electronic database search under the code of the atypical Parkinsonism, which include PSP, CBD, CBS, and MSA in all populations, including white, Black, and other minority or underserved racial ethnic population, including Hispanic, Asian, etc. And then once we get this database, then we first check individual chart information to extract the more detailed information, because the electronic database only contain some basic demographic information without detailed information. And also some of the information may not be even reliable. For example, the diagnostic accuracy. We did a study before. The accuracy based on the electronic database is only about 73%. It means that you could put the diagnosis of PSP there by various providers, primary care doctor, but in fact, when you really verify this patient by the movement disorder expert, only 73% of the chance they get an accurate diagnosis. So that's why we follow up chart review. It's very important to get more detailed information and more reliable information. Well, what are we looking for? We're looking for age at the disease onset, and also time interval from onset to the first care, which reflect the healthcare access. Even though we don't care what kind of level, what kind of physician, what kind of place the patient get the first care related to the disease, and also the time interval from the disease onset till the diagnosis is made. That reflects, how long would that take to get eventually referred to see the expert, also reflecting the healthcare access, and also tell you how challenging those atypical Parkinsonism to be diagnosed. And we also would like to get information on the frequency of follow-up and the location of care. With the different ethnic group get the different frequency of follow-up and get medical care at a different location. As we learn from Parkinson's disease, Black population more likely to get care in the ER and inpatient and less in the outpatient setting due to the various reasons, including the socioeconomic status as well. And also we try to get information on utilization of a treatment, including medication, but particularly supplementary therapy in terms of physical therapy, occupational therapy, and speech swallowing therapy, and home health care. And also for this atypical Parkinsonism, it's very important to emphasize the advanced care plan of palliative care and or hospital service, because the research has been again can show how would those kind of service improve the quality of care. And we would also get information on survival duration, and we also need to find what kind of fact could affect those different measures: demographic, race, sex, and the socioeconomic status, education, income, insurance type, and the comorbidity. So our preliminary data on this study so far, based on a total number of 248 patients with atypical Parkinsonism, with 158 patients with PSP, 21 with CBD/CBS, and 69 with MSA, in the duration of 2006 to 2024, because that's the period we're funded to study. And we found that compared to Parkinson's disease, they both belong to neurodegenerative disease on the same big category. And also they both present similarly Parkinsonism, even though atypical Parkinsonism or Parkinsonia syndrome pose more challenging because they have also additional plus symptoms. For example, PSP has supranuclear palsy, and CBD present with cognitive function, dystonia, and other mode of function and non-motor function. And the MSA also present with autonomic dysfunction. And also atypical Parkinsonism progress more rapid and also less response to medication. So they can have early onset of loss of balance, frequent fall, aspiration, etc. So that's why I make it more challenging, but still the close disease to compare would be Parkinson's disease. And what we found that atypical Parkinsonian patients take much longer time to get the diagnosis, get the first care, regardless of where to get the care and what kind of provider, PCP or neurologist, general neurologist, etc. It applies to any racial ethnic group, regardless of white, black, or Hispanic or Asian. And also, regardless of what specific individual disease they have, PSP, CBD, CBS, and MSA, they just follow the same pattern. On average, it takes about 1 year for patients with atypical Parkinsonism to get the first related care since the onset of the first motor symptom, which is pretty much double the time compared to patient with Parkinson's disease, because Parkinson's disease only take a half a year to get the first care based on our previous study in the same center. So it is comparable. And also we found that it takes a much longer time for individuals with any atypical Parkinsonism, PSP, CBD, CBS, MSA, to get diagnosed. And again, it applies to any racial ethnic group. It on average takes 3.5 years to get a diagnosis versus only 2.5 years to get diagnosis for Parkinson's disease patients. Why is that? The time is mostly lost for the referral. Once they get to our tertiary center, we can make a diagnosis right away for majority of cases. The 3.5 years is basically the take from the initial onset, primary doctor, neurologist, and more neurologist or other movement disorder specialist eventually get to a tertiary center. In the case here, it's our University of Chicago Cure PSP Center. So that poses a big issue here. And particularly if you compare the first time to get a first related care is only about 1 year after onset. But it means that additional 2.5 years lost during this referral system. So it really raised an issue of how we should educate the patient and family, which may not be enough. We should also educate the care providers, different levels of doctor, and even neurologists as well. And we also found that more supportive care is needed for any type of atypical Parkinsonism. Again, it applies to any racial ethnic group. The need for supportive care, PT, OT, ST, home health, is 50% more in patients with atypical Parkinsonism compared to Parkinson's disease. And also, we found more advanced care in terms of palliative care and hospice as needed for atypical Parkinsonia patient. Again, it applies to any racial ethnic group and apply to any individual disease, including PSP, CBD, CBS, and MSA. About 50% more in need of palliative care and hospice in atypical Parkinsonia patient than PD. So again, those data suggest an overall challenging in recognition and diagnosis, and then the overall need for supplemental care and advanced care in patients with atypical Parkinsonism, which apply to any racial ethnic group, share a similar pattern and any individual disease. However, there also might be some racial disparity or differences in the prevalence. As we can see, low prevalence in Black compared to white patients in any individual type of atypical Parkinsonism, regardless PSP, MSA, or CBD or CBS. The Black-white ratio is 1:4 in atypical Parkinsonism, while in Parkinson's disease is 1:2. It means that more challenging for the minority and underserved population, like a Black population, because the same exact pattern also applies to other combined minority group from Hispanic population, from Asian population. So it means that could be challenged in the time spent in the referral, in the recognition, in the first care, in the diagnosis. What is cause of that? Is that socioeconomic, culture, or other genetic or other biological factors possibly contribute to the difference? We don't know, but at least the possibility there, this complicated disease could cause more challenging for whatever the reason for the minority and underserved population. I mean, the data here is comparable. Why? Because we are comparing the Black-white ratio in the same geographic area, in the same hospital, in the same system. And you might want to know what's the ratio in the general population in the Chicago area, Black compared to white. It's about 1:2. So that's another reason to show you that atypical Parkinsonism in Black and underserved population is underrepresented for whatever the reason here. So further work is still needed to find, which is still ongoing, to find the information on the frequency and location of the care and the important survival duration of individuals with atypical Parkinsonism in different racial and ethnic groups. And we also would like to further pin down by conducting logistical regression analysis to find a potential confounding factor to control or other different factors, including socioeconomic status, demographic factors, and comorbidities to see if any factors could contribute or any difference as we just reviewed here. And eventually, we will compare our data from Dr. Bruno's data from University of Hawaii, even though we're not exactly taking care of the same type of underserved population, but I'm sure we are a lot of common ground to see if we can get more insight to the limitation and the possible generalization of our data in understanding and improving healthcare access. That's the fundamental goal, to improve the care for patients with atypical Parkinsonism. Again, I want to summarize what we have found so far in this sizable rare disease of 248 patients. And we found the challenge in the recognition and diagnosis of individuals with atypical Parkinsonism compared to Parkinson's disease, and possibly more so in the underserved and the minority population. And the need for more supplemental care and advanced care for those patient group. Why is that? Because they tend to change or deteriorating fast and are more severe in terms of symptom, and lack of enough response or prolonged sustained response to medication. But on the other hand, the supplemental care, PT, OT, ST, and speech and swallowing therapy all have been found to be beneficial for this patient groups. So that's why we need to emphasize the importance of supplemental care. And also the advanced care has also been shown to improve the quality of life as well. And what's the possible next step? Number one is, again, education to the patient caregiver to make sure that they are fully aware of the disease, the symptoms, so that they can seek a timely health care once they realize something changed. And also we need to provide more education to healthcare providers, different level, PCP, general neurologist, any specialist, as well, to help them fully understand the disparity and inequity so that they can facilitate timely referral to movement disorder expert for a better quality of life. And make sure we provide more supplemental care and advanced care to those patients in need. And also conducting more study to find more contributor factor and find more fundamental issues to help us improve the quality of care. Lastly but not least, worth mentioning is the advancing in science and technology, and the development of new diagnostic tool can also allow us to have an early and more accurate diagnosis, which can reduce the interval spent to get the initial diagnosis and also improved quality of care. Thank you, everyone. Your patient and family, everybody with us today, and the caregiver and provider as well, and our collaborator and Dr. Bruno and CurePSP staff for you joining us and for your great support. Thank you.
Great. Thanks so much, Dr. Xie. Now I guess we'll just kind of transition to a conversational period. I appreciate both of you and all the work you're putting into this. I know that it seems easy to everyone to have it on a few slides, but I know how much work went into this, and it's a super important topic. I have a few questions I'd like to ask you, and folks, if you have some questions pertaining to the topic, please feel free to share them into the chat as we're talking. But my first question is, I'm trying to think of how does language fit into this? Is this something that you've been able to study, or is that just a whole other ball game that's kind of in the future? I'm curious if you have thoughts or anecdotal evidence of that. Whichever one
Yes,
of you wants to take it.
yes, I'll
Thanks.
answer. Yes, I think that's a really, really important topic. I haven't specifically studied with this, don't have data to show. But for example, we did actually a study on restless leg syndrome, which is diagnosed with history discussion, and we don't have as much biomarker, just like Parkinson and PSP and MSA and CBS. So in restless leg, I think if you're not English speaking, you might have lower incidence. Again, it's not proven. We have to do more research, but understanding the concept and discussing it's so important. And I come back from, again, Japanese culture, but we may not be as expressive, and sometimes Asian culture thinks when you're slowing down, it's just old age. So there are all these, just not language, but again, language is really intertwined with culture. And so I think as much as I would like to collect data on that, and I think we're trying to collect more data to understand that.
Yeah, I fully agree. And also, I found I just briefly read through the questions from our audience. I'm wondering I can take this opportunity to answer some of the question there.
Yeah, we should try to stay on topic, but if there's something that you see, then happy to hear your thoughts on it.
Yeah, so I found some questions really interesting to me. For example, one question said that there's only 20 to 30% of diagnostic errors there compared to autopsy. I think that's true. That's consistent with our recent study. We compare our diagnosis, which is made by movement disorder expert from academic center, compare the AI diagnosis, and we found that our diagnosis accuracy by 82, which is really fit the number you talk about, 2030, and the AI diagnosis is about 94. So I think that really show amazing result that the future technology can help, and also how much we can learn from AI. So our study is now ongoing to see if we can learn based on this 94 compared to 82, what we can learn in terms of our clinical feature and our diagnostic criteria in the future to improve.
Yeah, really great insight. Michiko,
Yeah.
do you want to add anything or? Oh, you're muted, sorry.
I wanted to, yeah, no, that's a great. I think we really feel like the field is changing, and we'll have more technology and biomarker to tease out all these things, which is exciting. I did want to kind of answer a random question that I saw about Native Hawaiians, if Native Hawaiians are completely extinct. So, yeah, well, I mean, I wouldn't say extinct, but Native Hawaiian blood and culture lives, but there is really rare to see a complete pure Native Hawaiian like 100%. So when the disease wiped out about an estimate 80 to 90% of pure Native Hawaiian population at the time, the surviving Native Hawaiians really integrated into the rest of the culture. So most of the Native Hawaiian blood is now sort of mixed race, including Chinese and whites, and there are like multiple mixed race. So that kind of makes it even complicated. In fact, Dr. C was talking about Xie, sorry, I'm sorry, I'm getting mixed up.
So I
Dr.
think both
Xie was,
Dr. Xie and Dr. Z needs to work
Dr.
well.
Xie was talking, apologize. Was talking about how record could be like a little bit sometimes misleading, and we found that a lot in race and even language, Courtney, that you were talking about. So what we record may not be as accurate because mixed race is very difficult to standardize how we would record that. So again, like, with genetic advance, we may have a little more better way to understand this, but yeah, so I just wanted to
Yeah.
appreciate the interest in Hawaiian culture, and we have great thing. I think the native Hawaiian culture is really into like nature and grounding yourself in tradition, and we can learn from that as well.
Yeah, I think I agree. This is one of the interest points I found today. I found you are also running a genetic program to diagnose PSP and other disease. And particularly nowadays, we talk about co-pathology. I assume co-pathology
Yes.
meaning that the same brain can have two diseases. Like we think you have PSP, but you can have PSP MSA, and then or some other dementia, Lewy body, whatever things there. And some of them you can also find from genetic diagnosis. If you carry mutation A, mutation B, A for for this disease, be for other diseases, that can also help understand. And recently, I did encounter several patients. They present clinical PSP features. I would diagnose PSP, but not very typical on some extent in terms of balance and ataxia component. And eventually, I found the SCA27B. And then I checked the literature, found that in fact the pathology, co-pathology like this has been reported in a scientific journal. So that really also points to how fascinating and how interesting we should dig deeper to find more about the PSP, single PSP or co-pathology PSP or PSP with other disease, and how can we learn from this and better manage the patient and improve the quality of care. That's another thing. So I think in the future, we can collaborate on genetic study as well, because we have a larger patient sample as well for us to run the new studies to get more into it.
Yeah, it sounds like this is just the beginning. We're just kind of finding the lay of the land and then we'll carry on. So that's great. I guess that leads me to kind of another question is, with this data, where do you dreaming see this going? Like what with this background and this information, this data you can present to providers, where do you kind of hope and dream the top line is, or the overview of what you could teach people?
So I think it's from my study, I think it's at least at the step one, we learn the issue here. What is the issue? The issue is we found take too long time, delay the diagnosis. That would definitely cause the patient and caregiver lots of burden and financial and physical and mental. And also they expose unnecessary tests or probably unnecessary medication without to get appropriate treatment. That's one thing. The second thing is that also would affect future plan. For example, we found that we want to find a cure. We found a better medication. We need to run more effective clinical trial. How can we enroll patients at the early stage in the best condition? Because otherwise, when they diagnose, it's too late, right? It will make it us difficult to find the disease more modified agent otherwise. So this is from the diagnosis part. From management part, you can see supplemental care is particularly important for this one because their response to medication is less effective compared to PD. But the supplemental care becomes the leftover, and which is also being proven very effective. So we should really keep in mind as care provider to prescribe more to help them get a symptom better control. The other thing is palliative care and the hospice. This is not downside. This is a real one step up to improved quality care. Instead of using 10 different doctors in a couple of days, which make you exhausted, we can have a group of people. They really professional. They can combine different needs and provide one visit. They can even visit to home or institute. Study has been shown that would greatly improve the quality of care as well. So those are things we learn from it, and we should share with the patient. And this is also consistent with what we observed, but the scientific data just put a more convincing way to convince me as a provider, and also we can share this convincing patient and caregiver. Overall, we should take this as a first step to help the quality of care and to improve the diagnosis.
Yeah, I completely agree. Those are all really excellent points that we are always thinking. And I think I wanted to add one thing. I think Jack had some question about what about the other centers? Should we try to share more information? So I think that will be a really great in the future ideal state where we're going. If we could share data and have like a database of everybody of these disease in the country and even in the world. So I think there's a lot of course, we have to protect privacy, and there's a technical issue as well as infrastructure issue on those bringing those kind of database. But I think the spirit of collaboration with like just me able to collaborate with University of Chicago is amazing. We need help and resource and academic expertise from Dr. Dr. Tao. I call him Tao, so I apologize, but I'm just going to go with that.
And Dr. Bruno as well.
Yes. So So, but not just two of us, but all of us, if we could collaborate. We also need input. I see that everybody's willing to participate in research, and if you could keep kind of giving interest, keep advocating for yourself, telling your doctor, telling your you know, um, a healthcare provider, for example, even the speech therapist or physical therapist, initially, sometimes they don't know. So they're a little bit afraid to try to help. But if we could educate them, we really need the entire like multidisciplinary team to know about these. So I think the collaboration, but having a kind of a data and way to measure things and way to share that as an infrastructure would be great. I think we can make like progress in strides.
Collaboration is always so important. Um, and I also see lots of questions ask where to get the care locally. And I think this is a common question from a lot of audience. Uh, I, my suggestion they can send an email to CurePSP and they can also send it to us, me and Dr. Bruno, because we have a dedicated social worker here at the University of Chicago, and she can help connect the care locally to to find a best fit for you. So just feel free contact Cure PSP and me and Dr. Bruno, me and Dr. Xie or Dr. Z. Either way is fine. Don't worry.
Yeah, sorry to cause confusion there for some.
No, I think they both work very well here.
Sounds good.
I'm sorry.
Um, we are at 4 o'clock. That went by so fast, or 4 o'clock Eastern. I do want to just really hit home the point Dr. Bruno just mentioned of advocating for yourself. We have some healthcare professional resources that you can print out to your and bring to your appointments. You can email them. You can ask them to be put in your medical records, your electronic medical record. Feel free to email us if you want access to those. They are on our library, and really, this is a collaborative effort between all of our Cure PSP Centers of Care. This is a really beautiful example of that, and I thank you both for your collaboration cross country, truly across the ocean even. And this is happening all over, and so this is just really a shout out to our Cure PSP Centers of Care because this is not just these two, this is the whole center, and just a really great example of that. So again, if you have questions, I know that there were a lot we weren't able to address in the chat. Please email us at info@curepsp.org, and we'd be happy to point you in the right direction, connect you with resources that'll be helpful for you. Thank you both. Appreciate your time, and I hope you enjoy the rest of your days. Thanks, everyone.
Thank you so much. Thank you, everyone.